I'm often asked by student nurses, what does a matron do? My boss asks it sometimes as well, but student nurses ask, what do you do as a matron? And I'm not entirely sure, if I'm honest, apart from the biggest thing is to drive quality and standards. And that's within all of the team, because we can only deliver excellent patient care if we've got excellent staff care, and that's I truly believe that's where we have to start, with the staff. If you've got excellent staff care, in a heartbeat you'll have excellent patient care. So the stats I'm going to show you sort of back up that nearly, and without blowing smoke up anybody's behind, we've got an excellent team within TNO, and it's an MDT team, so there's some faces old and new, past and present in the room, that have been part or are part of that team. We do work, it's not a nurse-led discharge or a consultant-led discharge, it's a full proactive MDT that makes all the decisions on the ward. Clicker's not working. No, there we go. So some of the stats that I can show you that team drives. If you look in 2021, January, we had 288 patients that were waiting, elective patients that were over 52 weeks waiting for their op. And then 12 months on, as you can see on the figures here, RFT, that's us, we're at 11. We've only got 11, so we've driven that right down to 11. As you can see on the far right, some of our colleagues in the bigger places around us have got massive amounts of figures. Part of what drives this is we've had an amazing recovery programme, and it's all been led out of 14 beds as well, our elective ward. But the ambition and team ethos is to make sure it happens, and make sure it happens well. We've got a great programme of day case hips. We've got a pathway for that. We've got one consultant definitely doing plenty on that. We've got a couple more itching to get on that pathway, and I'm sure they'll be on it properly in the near future. We've got uni knees as day cases, so that recovery has all come by some real proactive work and engagement from all the team. Referral to treatment, we're not measured on that nationally now since COVID kicked in, but I'm sure it'll come back. But even that, as you can see, you know, from for the 18-week target, we're 68%, which is well above the national target. Barnsley are trying their best to catch us, but not succeeding. And then the two other trusts around us, the bigger ones, again, not doing quite so well. So that's why we want everyone. As well as staff engagement and staff quality, we've got a lot of patient engagement going on. We've recently started the Orthopaedic Plan Care Patient Panel. We've randomly selected 50 or so patients and invited them all to a panel face-to-face where we'd meet, and it was off-site initially because to find them big enough because of COVID. And we basically want to know what, throughout COVID, what do you want from us? You're waiting longer and longer to have your operations. What do you want from us? What do you want to know? And how can we develop and how can we improve? We've got lots of really good facts from them, and we've acted on a lot of them. Part of it was the website, which Mr. Kapoor, I believe, showed you earlier. There's a lot of things on the website like mental health information, wellness, because the other thing through COVID as well, what we are noticing now is most of our elective patients, which are our best, fittest patients, are coming in total of X. The ASA, we're getting more 3 and 4 than the ASA than we are 1 and 2. So we're signposting them to lots of self-help, etc. Hip and knee skull, so prehab. We've been doing this for a number of years now, and we're trying to make it obligatory so that they can't have the operation unless they've come to hip and knee skull. We're not far away from doing that. And for the physios who've worked on the wards amongst you, you will know without a doubt, you can tell the patient that's been to hip and knee skull at the side of the one that's not been to hip and knee skull, because that one's getting up, packing his bags and buggering off, and the other one's still in bed. And it really is that evident, it is, you know, so it's good practice, good practice. And then the next slide is just really a bit about the quality, and this is for the elective ward, but it does mirror both our trauma ward and fracture clinic as well, fracture and orthopaedic clinic. So the top figure, the core MAST. MAST is something that as health professionals, there's not many people like doing MAST training. We're at 99.3% on sit well for all the staff. FITS is at 98%, clinic is at 98%, and even our medics are at above 90%, which is unheard of. And that's been a real team effort to get it through. Patient safety, as you can see, we had a fall. We actually had a fall on the elective ward in January, but that's when the elective ward was a COVID sort of outlier ward. We got every patient under the sun on there, and we unfortunately had a fall. But other than that, the figures speak for themselves. You know, it's usually very good records on patient safety. And then this slide I particularly like with the infection rates. As you can see, for our elective team, infection rates are 0, and bare below elbows, and compliance with, you know, the bare below elbow from the medics and the nursing staff is excellent, and that's why we maintain the figures and the quality we do. Now, moving on, what we are hoping to do, which we should have done 12 months ago, is move wards. The plan was to move wards into a 28-bedded ward. COVID then peaked, we couldn't move, and then we were going to do it again about 3 months ago, and again COVID peaked and we couldn't move. The plan is there's some discussion next week, and we're hoping that next week we'll get the green light for first kink in the chain to move, which is another ward, but they need to move off so that it will enable us in about 3 months to move on to a 28-bedded ward. That 28-bedded ward will give us the ability to sort of flex. We're going to have some infection control, signed off electronic doors throughout the ward, so that in times of need, like at Christmas, when we're getting more trauma, and normally we close down for the elective to accommodate the trauma, we'll be able to keep at least 8 beds for elective and still accommodate the trauma that's required. So that's going to give us more management of all our patients, both trauma and elective. We are having to go through all site management, etc. As I said, the daycare SIP and knees, we're progressing those, and they'll move at a faster pace, I'm sure. MDT I've talked about, and the staff as they are. And like I say, there's no, you know, straight John Bull really. If they need a telling, they'll get a telling. But they are the fantastic team within orthopaedics, all of them. So, and that's me about done. Thank you very much. Any questions?